It is with immense pleasure that I welcome to today's From the Front Lines Surgeons' Voices series, my friend and fellow Regent, Dr. Anthony Atala. Dr. Atala is the W.H. Boyce Professor of Urology, Director of the Wake Forest Institute for Regenerative Medicine, and Chair of the Department of Urology at Wake Forest School of Medicine. Welcome, Tony.
Great to be with you, Steve. What a pleasure.
Well, you have quite a recent accomplishment, being in the highest impact factor of any journal in the world, the New York Times, having your work cited there, really across households, across the entire planet. Congratulations, well deserved for the incredible work you've done in regenerative medicine. I'd like you, if you would please, to start off telling us a little bit about the initial path of research in regenerative medicine and your goal to create tissue and organ therapies, which ultimately would get to patients.
Yeah, absolutely. So as you know, we're working right now with a body in a chip for COVID, but really it all started with our early work where we were trying to engineer tissues for patients and to try to really get organs built in a laboratory, really. And that really entails taking a biopsy from the patient, expanding the cells outside the body, creating a construct outside the body, and then putting that engineered tissue back into the patient. And that's how this work really got started about 30 years ago.
Who were some of your collaborators? What types of brain trust did you need to get this project off the ground?
Yeah, you know, it's interesting. One of the things that had happened is that if you look at the early days at MIT, and a burn surgeon at the MGH, Dr. Burke, and there was a collaborator at MIT, and they both ended up working together to try to grow skin cells, actually, for wound healing. And what they were able to show back in the 1980s was that if you were able to place those skin cells over the wound, it didn't necessarily make new skin, but it did help to enhance the wound healing process. And the scientist at MIT was Yanni Yanas, and the surgeon at the MGH was Dr. Burke. And that really kind of, was one of the very first instances where you could actually use cells to try to heal patients. And of course, then the field kept progressing. And when I got involved in the field, it was really one of those things where, as a urologist, we were trying to look at alternatives for intestinal tissue for bladder reconstruction. Because as you know, intestine absorbs things, whereas the bladder is supposed to secrete things. So that's not a good combination. So really trying to create a tissue that we could actually implant inside a patient that would really replace that tissue functionality, if you will. And we started that work around 1990, and by 1998 we were able to place that first organ into a patient.
Fascinating, and now we're 30 years into your work. From the work by Dr. Burke and his collaborators on burns, we've come from a very thin layer of cells, which, although it's three-dimensional, is sort of limited three-dimensional as compared to a bladder, which is very three-dimensional as an organ. How did 3D printing impact your research along these 30 years?
We started with bladder tissue, and in fact, when you engineer the tissue, you have to really go through a very tedious process of doing so. And really, the bioprinting was a scale-up tool. So when we started with a bladder, it was actually a level 3 organ. We basically classify organs based on their complexity, with flat structures like skin being the least complex, because they're flat architecturally. Tubular structures being the second level of complexity, hollow non-tubular organs like the bladder being the third level of complexity, and finally solid organs like the liver or the heart being the highest complexity. So we ended up starting with a level 3 organ. If we had known back then what we know now, we would have never started with such a complex organ. But by doing so, it really allowed us to go and target some of the less complex organs like flat structures and tubular structures. So after going through a whole line of tissues that we start to implant in patients, we start creating these by hand, like skin as a flat structure, or urethras as a tubular structure, hollow organs like the bladder, vaginal organs, using kidney cells for therapy. We went in this stepwise fashion, getting these therapies into patients. But one thing was clear, and that is that it's okay to create these by hand when you're doing these for small trials for patients. But if you really want to scale up the technology, you really need to automate it, and you really need to scale it up. And that's how we started working with 3D printing. Of course, it was not called 3D printing back then. It was just we started by using your typical desktop inkjet printer. But then we started to modify the technology to get to where we are today, building printers specifically to create tissues and organs.
Fascinating, absolutely pioneering, innovative work. Congratulations. You talk about scaling up, but on the other hand, the article in the New York Times was perhaps scaling down, if you will, and looking at miniaturizing tissues and organs so that you could do things like drug discovery, toxicity testing, personalized medicine, using these body-on-a-chip systems with 3D printing. Could you talk about that particular facet of the research for us?
Absolutely. You know, it's interesting. We had engineered these tissues and organs for patients. And of course, the challenge when engineering structures for patients is to make sure they have the right vascularity, right? Because that's really what you need. And so creating tissues which are larger becomes more complex. So around 2002, the year 2002, we actually put a proposal together that was, why don't we use these structures and miniaturize them so we could, in fact, use the same strategies that we use to regenerate tissue, right? Using the cells and the glue that puts the cells together, what we call the matrix. And why don't we miniaturize the system to do drug testing, discovery, toxicity testing. And that was back in 2002. And so it was actually an idea that took time to take traction. And eventually, of course, we started getting into this area that we now call body-in-a-chip area, or the organoid area, where you really miniaturize these structures, but we make them in the same manner that we would to place tissue into a patient, right? So, for example, if we're trying to create a structure like the liver, it's got 6 different cell types in different proportions. And each of those cells plays a major role. So we want to make sure we put all those cells together, we engineer them together, we put the right glue together, which is the extracellular matrix, but we do it in a miniature manner. So the size of each of these miniature structures is about the size of a pinhead. And by creating these with normal human cells, primary cells, we then are able to create these 3-dimensional structures that really do replicate in many ways the physiological systems of a normal organ, like a liver, for example. So our miniature livers secrete urea, they secrete albumin, they metabolize drugs. If you give them Tylenol at toxic levels, they become toxic. If you give it in acetylcysteine, it rescues the liver. So they really do function like what you would expect physiologically. And then we started to create these structures, and we started to create these for all these different organs that we were working with in the laboratory for patients, and for experimental purposes. So liver, blood vessels, kidney, heart, bladders, testes, ovary, to make sure they're male or female, miniature structures, gut, lungs. And by putting them together, we can create what's called the body-in-a-chip, which microphysiologically can replicate a lot of the components that normal human tissue have.
That's unbelievable. It really is. It sounds science fiction, but thanks to you and your incredible innovation, you've turned it into reality. Body-on-a-chip system is what was discussed in the New York Times article, specifically relative to COVID-19, clearly the hottest research topic at this current time. Please take us through a little bit about how the body-on-a-chip is used in COVID research.
Yes, absolutely. So we are using the COVID virus to look at both infectivity and antidotes, as well as toxicity of the antidotes. So, for example, if we just take the regular system that we currently have, the body in a chip, which, you know, many people are now working on these technologies, that if we take now this body in a chip, we created this system and that where you can combine all these tissues together. And so you now start to see things that really replicate, as I mentioned, the natural response. I'll give you two examples before I get into the COVID, so you see how we use that as a basis. But for example, there was a drug called Hismanol. It was an antihistamine that was used for 11 years in the marketplace, approved by the FDA. And this drug had been tested in cell lines, and the cell lines did not show any toxicity. They were tested in small animal models, no toxicity. They were tested in phase 1, 2, and 3 human clinical trials, no toxicity. It was released into the marketplace. It took 11 years for there to be enough cases of patients having heart block where they connected the dots to say the heart blocks in these patients are being caused by this one drug called Hismanol. And finally, the drug was recalled by the FDA, taken off the market. We actually got a hold of that drug. We tested in our system, and within 2 weeks, we knew the drug was toxic in the same dose response with the same effect, the heart block. I'll give you one more example, a bit more tragic. Resolin, an anti-diabetic, same thing, was tested in cell lines, animal models, phase 1, 2, and 3 clinical trials, no toxicity. Finally, it was placed into patients. Within 3 years, there were 63 deaths due to liver failure. Drug was recalled. We got a hold of the drug, tested in our system. Within 2 weeks, we knew the drug was toxic to the liver. Same mechanism of action, same dose. Why the difference? The difference is because we are really getting rid of all the noise, right? Everybody metabolizes drugs differently. First of all, cell lines are not real tissues, right? They're just cells in a culture plate. Animal models don't necessarily replicate the normal human response. And in clinical trials, you're dealing with many different patients that have different metabolic pathways. They process drugs differently. They have different genetics. They have different epigenetics. They're going to process drugs differently. When you're creating these body and chip structures, you're really getting rid of all the noise. It's really just the human tissue with the drug or the infective agent. And so here we come with COVID now. So this can be very helpful because in reality, when you're testing these drugs, you can see the response in human-like tissues that really represent at a very high level the response you would see in a human, rather than cell lines in a culture plate or animal models. And you can get rid of all the genetic and epigenetic noise, if you will. And so we're using these systems to test infectivity with the virus at different organs, because different organs have different levels of infectivity, and at the same time looking at antidotes that would actually provide this process for them. So, and we're doing this using several different antidotes. For example, one of the antidotes is from, that we're testing is for the lung, a lung antidote per se. But one of the other antidotes is an antidote for the gut. And the antidote for the gut is very interesting because it's actually an antidote that is being produced as an antitrypsin antidote by a group of individuals called Leading Biosciences. And this is an interesting antidote we're looking at for the gut. And then we have collaborators like Dr. Arthi Narayan at George Mason University, where we're looking at this with a CDC lab, looking at these different agents and how they actually affect these organs.
Absolutely first-rate research, cutting-edge research, very, very impressive work that you're doing, and I'm sure that it's going to make the way we practice medicine and surgery quite different in the not-too-distant futures. Any other comments with which you'd like to leave us about the direction of your work or where you see it going next?
No, thank you, Steve. I think you've asked great questions, and it's nice to share this with you.
Well, it's a privilege to be with you today, and it's an honor to sit with you on the Board of Regents. You're an incredible academician and scientist, as well as a first-rate surgeon. So I feel quite privileged to be with you at our meetings and today as well. Thanks for sharing your time and your insights, and stay well amidst this pandemic.
It's great to be with you and best to you.